Good afternoon. Thank you for selecting our research for the oral presentation. I'm pleased to present you our project regarding AI-supported quality improvement to optimize polypharmacy in aging people with HIV. We know that people with HIV have comorbidity 3 years that is lower than in the general population, and it is well known that multimorbidity risks are higher in people with HIV, especially in people aging with HIV. And that also increases the risk of polypharmacy across different age groups, as multiple studies have shown in the last 15 years. And what has been also shown is that the probability of polypharmacy increases with the duration of HIV infection. So we know that people who have been living with HIV for more than 20 years have a higher risk of polypharmacy. The polypharmacy is also determined by higher risk of drug-drug interactions, which are still important issue in people with HIV, although we reduce the use of boosted protease inhibitors regimens in people with HIV. However, multiple observational cohorts have shown that the DDIs are still an important and relevant issue in people with HIV. Another issue that should be considered in people with HIV when we talk about polypharmacy is also inappropriate prescription. And EACS guidelines provides an algorithm in which we can assess polypharmacy drug interactions and inappropriate medication. So we have a precise guideline in which we can assess these risks in people with HIV, using also some additional tools such as HIV drug interactions website or BIR stop and start criteria. Knowing all this risk and knowing that we are dealing with a very vulnerable population of people with HIV that have higher risk of polypharmacy, the study objective was to describe the integration of quality improvement intervention in the Modena HIV metabolic clinic to enhance the management of polypharmacy. In particular, we assessed drug recognition and reconciliation list, assessing the agreement between medications recorded in the electronic patient chart and those submitted by the patient. We also quantified the number of active pharmacologic agents and pill burden, and we also assessed the risk of inappropriate prescription, and we determined the rate of physician acceptance of pharmacist recommendation and integration into patient care plans. To describe our quality improvement project, this was a cross-sectional observational study that included people with HIV more than 15 years old who were attending Modena HIV metabolic clinic, and the quality improvement project included multiple steps. So the first step was 1 week before the visit, patients received an email requesting an update on their current medications. The email contained a WhatsApp link where patients can submit photos of their medication. In the step 2, the patients were instructed how to take photos of their medications, and they were also provided a tutorial video that shows them how to take photos of their medications. So they were submitting photos, making sure to capture the barcodes of the medications and also sometimes the drug name. Then when they sent the photos, they had interaction with our AI system that asked them to specify the dosage and the administration during the day. The patients were asked to upload one photo at a time, not the photos of all medications that were taking. The step 4 is that these medications that we received via this system were recognized by AI-powered drug recognition that extract the data, medication details through barcode and OCR technology. The AI system matches each drug with standardized name and classification. So we used ATC, International ATC code classification system to recognize all the drugs, and all this data was automatically uploaded into electronic patient chart that the physician during the medical visit was able to see. So this is the image that shows all the medications that patients that a single patient was taking via uploaded photo. So this reconciliation list was reviewed by the physician, and we were also able to see the differences between the uploaded photos and with the historical data that we had in our electronic patient chart, and to make sure that we have the complete reconciliation list, and we were able to see the differences between the old data and the data uploaded by the photo. So all this data was integrated with the NavPharma database system. That NavPharma is a database that analyzes drug-drug interactions, potential inappropriate prescriptions, QT prolongation risk, and kidney toxicity risks. And the PDF file report was generated, and it was sent to a clinical pharmacist that reviewed all these reports and then provided a final summarized report of potentially inappropriate prescriptions in people with HIV who adhered to this study. So this was the final output of the pharmacist review and of the clinical recommendations that occurred after all these previous steps were applied. So the outcome of our study was to establish the agreement between electronic patient chart listed and patient-reported medications. Secondary outcomes included the assessment of drug-drug interactions, potentially inappropriate medication, anticholinergic burden, QT prolongation risk, nephrotoxicity, pill burden, total number of active agents, and proportion of pharmacist recommendations accepted by physicians. And these are our results. We included 181 people with HIV who submitted photo, and of these 181, 98 were reviewed by the pharmacist. Median age of our population was 63 years, 72% were males, and median time since HIV diagnosis was 31 years, meaning that we are talking here about very vulnerable population of people living with HIV. Complete agreement was between medicines listed in the patient chart and those submitted by the photos. Was the complete agreement was observed in 61% of people, while 39% had suboptimal agreement, meaning less than 100%. So we also identified that 28% were prescribed medications that were recorded in our chart, but the patient was not actually taking these drugs. 34% were taking medications that were not documented in our system, in our electronic patient chart, and almost 12% initiated new medications, and 11% had medications that were discontinued during Modena HIV metabolic clinic visit. Regarding HIV-related variables, according to agreement, we did not observe any differences between these two groups, and also regarding multimorbidity and polypharmacy, we were not able to observe any differences. In particular, regarding hypertension, dyslipidemia, diabetes, osteoporosis, multimorbidity, and frailty index. Also, when we assessed all polypharmacy risks along with the inappropriate prescription, we did not observe any differences between these two groups. Regarding pill burden was 6 pills per day in our population, with 10 pharmacologically active agents that people with HIV were taking. Major DDIs were observed in 71%, and 60% of minor DDIs were observed. Anticholinergic burden prevalence was 26%. Prevalence of QTc prolongation was 82%, and nephrotoxicity, potential nephrotoxicity prevalence was 96%. Medications were discontinued by the pharmacist in only 3 cases. So in detail, anticholinergic burden, we identified 26% of total number of people, of 26% of people who had anticholinergic burden risk. 26% had higher anticholinergic burden risk. Regarding QTc prolongation, we identified that less than a half had high or moderate risk of QTc prolongation. And regarding nephrotoxicity, although that almost all people with HIV had at least one drug associated with potential nephrotoxicity, 40% of drugs had high risk of nephrotoxicity. The strengths of our study include automation of medication input, integration with the electronic patient chart, emphasis of multidisciplinary care, and also AI-derived data with pharmacist expertise, enhance safety, and optimize clinical decision-making. Limitations of this study include that we included the population of older people with HIV with very, very high burden of multimorbidity and polypharmacy, which means that these results may not be applicable to broader population of people living with HIV. Also, we were not able to capture polypharmacy in the most vulnerable older people with HIV who might not have access to internet or digital tools, so we're not able to submit the photos. And in conclusion, this project showed that AI technology, along with clinical judgment, improves polypharmacy management in aging people with HIV. Medication reconciliation and identification of inappropriate prescription were facilitated and more accurate. And this project supported the integration of pharmacist-led reviews into the routine care to enhance medication safety in aging people with HIV. Thank you for your attention.
Yeah.